right. Well, hey guys, sorry we had a little technical difficulties, and actually Dr. Malamed, he has his power's out of his house, which makes sense because there's some raging fires over there in California, right, Doc?
Absolutely.
Well, I
fires,
posted.
but the winds are really blowing up like literally hurricane force winds.
Oh my gosh. Oh
Yeah.
my gosh. Okay, guys. So here's the thing. We're using a different platform that we normally use because there's some technical difficulties. I will be checking in the Facebook group about any questions, but I wanted to bring Dr. Malamed on because number one, I posted in the group about, well, how many people actually had to read this book, right? And literally almost everyone did. I still have my book from dental school down. This is Dr. Malamed. I have the 5th edition. I have the 5th edition. So that should kind of let you know when I graduate school.
Absolutely.
But I'll tell you what, I still refer back to this. And what I actually like to do too, now that technology has kind of gone where it is, I like to go look for your videos on YouTube.
Yeah, thank you. The videos are not supposed to be on YouTube.
Oh, they're not supposed to be. Okay, well, I'm not going to mention who put it on there, but I'm telling you right now, it's been very helpful.
Yeah, you see, the thing is, the videos were made by Elsevier, the publishing company, the company that publishes that book, and they sell, in quotes, sell for money DVDs. And what people do is they put them up on YouTube. So every once in a while, Elsevier contacts YouTube, they take them down, and the next day they're back up. So
wow, that's funny. So, you know, I put a poll in the group, and, you know, this group is Nifty Thrifty Dentists. We have over 18,000 dental professionals in there. I did a post with this book. So many people have talked about how it's helped them. And so in the poll, I asked everybody, well, how do you make local anesthetic more pleasant for your patients? And the answers range from, you know, going really slow when you're doing your injection there. Some people talked about shaking the cheek, do a little distraction method. You know, people have talked about using the wand, using, you know, and then I put in there buffering anesthetic. And there's only a few people that checked that box off. And I was so surprised because I learned about buffering anesthetic, gosh, about 6 years ago. And there's different companies that do it, down to people who actually did it themselves.
Right.
So while we're waiting for people to put some questions into the comments section, I was surprised that not too many people knew what buffering anesthetic is. So Dr. Malamed, if you don't mind, just kind of explain the whole concept and why that is something that would make things more pleasant for your patient.
Well, let's first of all start by saying that whomever told you that injecting slowly is the best way to make it comfortable is 100% correct.
Okay.
Slow injection is really the answer to painless injections. The problem is, my experience has been over the years that most dentists inject too fast. And, you know, speed kills, speed hurts. So that's the answer. Now, let's go back to buffering though, okay? Buffering in dentistry is new. You learned about it 6 years ago. It's probably been closer to 10 years that, almost 10 years, that it's been available in dentistry. But it's been used in medicine literally forever.
Wow.
And the reason is that, first of all, the only physicians who actually use local are plastic surgeons, I'll remember it, allergists and dermatologists. And injecting local anesthetic in skin is probably as painful as a bad nasopalatine injection. In other words, it hurts like that. And what physicians have done is buffer forever. So I was contacted by, it's a company called Onpharma. These are people, Dr. Mick Falkel is the general dentist in Monterey, California, and he's the one who's really started this entire concept in the dental profession. And what we did was we looked at a lot of the articles that were written in the medical journals about buffering locals. And we found, number one, that it does make it more comfortable when done properly. Okay, when done properly, it makes the injection much more comfortable. But there were some other benefits that are, I would even say, are as important. Okay. It makes the local anesthetic work a lot faster. Onset of pulpal anesthesia is dramatically more rapid. It's more comfortable. And whenever you get an injection in the mouth, let's say a mandibular block, okay?
Mhm.
The next morning, when you wake up and open your mouth, even though you're not numb, it's sore.
Sure.
But two things are happening. One is, of course, a needle is going in, which, in quote, it damages tissue. Needles damage tissue. But number two, the acidity of a local anesthetic, which contains epinephrine, is around 3.5. Okay, now, you understand that 7.0 is neutral, above 7 is an alkali, and below 7 is an acid. 3.5 is highly acidic. And in fact, I show in my lectures a picture of lemon juice, because concentrated lemon juice is a pH of 3.3. So imagine cutting your finger and pouring lemon juice on it. You wouldn't do that because it's going to hurt like hell. So the day after you get the injection in the patient's mouth, they're sore from the needle stick and from the acidity, which is damaging the tissue. So what we're doing with buffering is we are raising the pH to around 7.3 to 7.4. It's in the slightly alkaline range. And again, that confers, number one, it's a more comfortable injection because you're not putting an acid into the patient's mouth. The next day, there'll be much less soreness. But I think really the important one is it makes the anesthetic work so much faster.
Yeah, it makes the anesthetic works faster. You can start faster.
Well, the study we did, it was published in 2013 in Compendium. It was a pilot study, and there were 18 patients in the study. Okay, they all got inferior nerve blocks with lidocaine with epinephrine, and they got it twice. On one occasion, it was a blinded study. So on one occasion, they got the traditional lidocaine with epinephrine, pH of 3.5. The other time they came in, they got the buffered lidocaine with epinephrine at a pH of 7.3. Now, I was the observer. There was somebody else who gave the injections. Neither one of us knew what the patient was getting. But after probably watching 4 or 5 patients get the injections, we could guess, and we guessed correctly almost every time, because the onset of anesthesia with the traditional lower pH lidocaine was 6 minutes and 36 seconds, which is the normal following an inferior nerve block, versus 1 minute and 51 seconds.
Wow. They
got numb fast. And these are the same patients coming in twice, and it works. Now, we did this study back at, this is, 7, 8 years ago. Well, 2013 was published, so it was probably 2011 or 12 when we did the study. We did it with lidocaine because that's the most used local anesthetic in the United States in dentistry. We picked the inferior nerve block because it's half the time, that's what we're doing. We're working in the mandible, and it's a tough injection. Okay, and it worked beautifully. So that was the first study that was done. Now, let's go back to the do-it-yourself thing, okay? Because I've been lecturing about buffering now for 7, 8, 9 years.
Dr. Malamed, there's a question that just popped up, and I think this is pretty, maybe we should field this question. Someone just asked, what do you buffer the anesthetic with? And so for someone who doesn't know what that is, let's kind of discuss that, what that involves. So this question was, what do you buffer the anesthetic with?
Sodium bicarbonate. Sodium bicarbonate. And the doctors, in fact, who DIY, do it themselves. Okay, I had an email from a doctor who said he read an article that I wrote about buffering, and he went to Walgreens pharmacy, and he bought a bottle of sodium bicarbonate, and he said in his email that he was following my recommendations, which I don't know because I've never done it.
Yeah, do you have like a recipe floating out there somewhere?
But he said that, and he said he was having a great result with it. Here's what we found when we looked at the medical profession, what they were doing. Some of the physicians were using 1 part of sodium bicarbonate to 10 parts of lidocaine. By the way, in the medical profession, lidocaine is really the only local anesthetic that is ever used. They don't use cartridges; they use multi-dose vials of drugs. Mm-hmm. And the by far most used local in medicine is lidocaine with epinephrine 1 to 100,000. Okay, so he bought the bicarbonate. He would take his cartridge and empty out a little bit of it. But so what they were doing was 1 part of bicarbonate to 9 parts of lidocaine. Others were doing 20 to 1, 30 to 1, 5 to 1. And the results in medicine were all over the place. It worked, it didn't work, whatever it was. Okay, so this guy was doing it. And in his email, he said to me, I was having great results with it. However, today a patient came in and had a swelling in his cheek the size of a golf ball. Mm-hmm. Can you tell me why this happened? Okay. Now, there was one more line in the bottom of his email that he actually answered it himself. And what it was I had just opened a new bottle of sodium bicarbonate. So here's the thing. Let's go by truth in advertising. Okay, lidocaine 2%. It says in the label 2%, right? So my question to a dental student would be, what is the concentration of lidocaine in a cartridge of 2% lidocaine? And the answer, of course, is 2%, right? That's an easy one. What is the pH of the sodium bicarbonate? Because what you're doing, a buffering agent, when you put a little bit of buffering agent into a other solution like lidocaine, you're raising the pH of the lidocaine to the pH of the bicarbonate. Okay, so if the lidocaine starts as 3.5 and you add sodium bicarbonate, that's 7.3, you wind up at the 7.3 pH in the cartridge. Okay, now here's the problem. It says on the bottle of sodium bicarbonate, the pH is 7.0. But in parentheses, it says next to it, it may range from 6.5 to 8.5.
Oh, wow.
Yeah. Oh, wow. So what happened was the first bottle of sodium bicarbonate the doctor went through had the right pH, and he was getting good results. He buys a new bottle. Unbeknownst to him, the pH of the new bottle is a lot higher. It's a hypertonic solution. When you inject a hypertonic solution into a patient's mouth or anywhere, it sucks fluid out of cells and produces edema. That's the answer right there. So that DIY is the least expensive way of buffering, but that is the only complication you may get.
Because you don't know, it's not an exact science.
You have no idea. You have no idea what the pH is of that solution. Okay, so
now,
what
other than causing the edema, what other complications might someone run into?
Zero. And bicarbonate is very, very safe.
Okay.
Very, very safe. And I show photographs of two, this is a New Orleans lecture I gave, and two doctors who were DIYing it, do-it-yourselfing it, sent me photographs of two children who walk out of their offices with swollen lips, swollen cheeks. I can imagine the parent when a kid comes out of the dental office and sees their face swollen, like, what on earth did you do to my child? But that's really the only negative to it. That's it. You mentioned there's a couple of companies out there. So let me just talk about them, okay?
Sure.
There's a company, Anutra, A-N-U-T-R-A. Now, it's called Anutra Medical because they have been selling a buffering system to the medical profession forever, ever, 10, 15 years, okay? And what it's doing is basically doing it yourself. You have a bottle of sodium bicarbonate. The problem, of course, is the pH.
Right.
The only local anesthetic that you can use with their system is lidocaine, 1 in 100,000 in a multi-dose vial. And you're using a syringe, a plastic syringe that they have designed. So you're changing the way you're doing your injections. Dentists do not like change. This is why so many of the doctors in your survey didn't hear it, are not buffering or haven't heard of buffering, because dentists don't like change. And you're changing everything about giving an injection when you're using the Anutra system. So what they're doing is they're well established in medicine, and they think, okay, and where can we go next? Well, let's go to dentistry. And over the last 3 or 4 years, I talk about buffering a lot in my lectures. And I ask you, who's doing buffering? And the ones who are doing it are either DIYing it or using Onset. We'll discuss that in just a little bit. But I've met 8 doctors who have used the Anutra system, and of those 8, only 1 liked it.
That's not a good ratio.
Again, and the reason, of course, is because it changes everything.
Right.
It's an alien syringe. You can't use Articaine. You can't use bupivacaine. You're limiting yourself. So that system, the only reason I think it's in dentistry is because it is in medicine, and they wanted to make more money. So let's go to the dental profession and see what happens.
But what better way, Dr. Malamed, what better way to make money than go and sell it to a bunch of dentists?
Yeah, who love
We're like the low-hanging fruit to some of these companies, don't you think?
I know. Well, they love dentists love gadgets. I love gadgets. I mean, we all do. But I think every dentist who's been in practice long enough has a closet or room filled with gadgets that look good and don't work.
No, absolutely.
Gathering dust. I've been involved over the years with electric anesthesia, and so many other things. And
So, Doc, let me ask you this, because that was on the poll. There was all these different gadgets. We had the wand, right? The STA system, the wand. Then there's the I think the Vibraject or something.
right?
And then
Greg, 1 minute. Wait. Let's go back to. So you said the wand. I'm going to give it 2 thumbs up.
okay,
And then you're going to go to the Vibraject.
yeah.
I'm going to give it 1 up and 1 down, or medium in between. And the reason is for that one is because it's the equivalent of shaking a patient's lip.
Yeah.
Okay, if you want to spend the money to buy a Vibraject, go ahead and do it. But you can shake the patient's lip.
Now, let me ask you this. What about compound prescription grade topical?
Oh, shoot. You know, the ADA and the FDA have come out against it.
Really?
Because there's no standardization when it comes to compounding. And there have been some mistakes that have been made where something that was supposed to be a 5% solution was a 50% solution. You know, and again, there are statements from the ADA saying it should not be done. The FDA has said exactly the same thing. A lot of doctors swear by it.
Yeah.
And whatever the concoctions, I mean, people come up with their own concoctions, put their name on it, you know, Malamed super topical anesthetic, whatever it may be. Topicals work. You know, look, we have topical benzocaine, we have topical lidocaine, and if you put just a little bit on a cotton swab and you leave it at the injection site for 1 minute, you can puncture that soft tissue without hurting the patient. Okay, I don't understand where these special topicals are going to be more beneficial.
Okay, yeah. Just wanted to get your opinion on that. So let's go back to buffering, because there was something that I read someone talking about buffering, and that is like when you buy the sodium bicarbonate, they come in different vials, right? But Doc, when you open it, what happens there? When you open that vial and you add it into the anesthetic, what happens if you try to go back and use it again?
Oh, yeah, you're talking about the multi-dose vial, the DIY.
Yes. Yes.
What happens to it really is nothing. You can use it until it's used up. Nothing bad's going to happen to it. Okay. Not at all.
Now, because I watched that, and again, we're going to bring up YouTube again, because before we jumped on, I went on there and I've learned how to do it yourself, because I've read all these things online. But then I saw there was actually 3 or 4 videos of dentists showing people how to do it online on YouTube.
Yeah.
And so, like I said, what you just said there, when you're doing it yourself, yeah, you're going to save some money, but the negative is the edema, right?
The edema. And really, that's about it. But okay, so let's then go. We talked about, so DIY, a Nutra is basically DIY with a fancy little setup. Well, what it is, really, it's what it is. And then the other one is Onset. So let me just talk about that, because this is the company that started this in dentistry. And I'm going back easily about 10 years when I was first contacted by them. By the way, I did research for them, but I am not a paid consultant to the company. That's my disclosure to you right now, okay? The whole concept, Dr. Falkel, was looking for a way over many years to take that sodium bicarbonate and to guarantee that the pH will always be the same.
Mm-hmm.
All right. In other words, it's not going to be from 6.5 to 8 point, whatever it may be. It's going to be within a range between basically around 7.35. And it took a long time to do that. Okay. So once he did it, and we did that study with the 18 patients, and we found that in under 2 minutes, 2/3 of them were numb in the mandible. Okay. So we started doing the research, and here's what is actually happening is that when you put the bicarbonate into the local anesthetic cartridge, and it's a very simple system. You have to buy into a system, of course, okay? But you're changing the pH literally that fast from 3.5 to 7.35. You put the cartridge, and by the way, it uses the regular dental cartridge. You put it in a syringe, you give the injection, okay? And again, you have a much more comfortable injection because you're putting a drug in that's not acidic. It's the same pH as the body, number one. Number two, you will see the onset. I mean, the onset of it's called Onset, by the way. That's the brand. Well, for good reason, because it does work faster. In fact, what we've been teaching our doctors to do who use buffering, and this is a tough one for most dentists, because we found that following I'm going to use that generic term, mandibular block. Following a mandibular block, most dentists will get up and leave the room and do a hygiene check or paperwork for about 10 minutes. We found 10 minutes is about average. What we want you to do is you buffer the anesthetic, you give the injection, and you sit there. You don't get up. That's hard, and what you do is you talk to your patient, and in 2 minutes, you pick up a pulp tester or endo ice, test the tooth you want to work on, and go to work. And if they feel it in 2 minutes, you repeat the injection. So see, one of the things I never do in my lectures is get into pricing. I try to avoid that. Yeah. People ask me, what does it cost? And to all your audience, I hope these are not the traditional dentists, but dentists are cheap. They don't want it. Everybody wants to buy a laser. Everybody wants to buy a CAD cam. They want to buy a CERAC machine. But when it comes to something like local anesthetic, which for a patient is the most important thing in the dental procedure, they don't want to be hurt. Okay, we're going to speed up the onset, make the injection more comfortable, and make the injection more profound. That's some recent research done in endo. It was published in the March issue as a cover article, in fact, on the March issue of the JADA journal, where they took buffered local anesthetic on mandibular and maxillary pulpally involved teeth, and they found it had a much higher success rate than the non-buffered local anesthetic. So what you're doing then is after 2 minutes, you pulp test the tooth with a pulp test. It's a regular tooth. It's not pulpally involved. And you can go to work in 2 minutes. Or if they do feel it, you repeat the injection. But think about that. You're not waiting 10 minutes to realize that you missed. You're waiting only 2 minutes. So even though I don't get involved in the monetary part of this, and I try that on purpose not to do that, is if you can save 8 minutes per patient over a day, either you go home an hour earlier or you can fit another patient in. So whatever it does cost for this system, if you want to call it that, a system, you more than made up the money.
And then also post-operative comfort, much right? More comfortable. They feel better. I mean, that's a practice builder right there. So Dr. Malamed, we got a bunch of questions. Can we field some questions right now? So I'm going to pick this one that I thought was really interesting. Someone asked, is it true about eating artichokes and your blocks?
You see my hands?
Have you heard that before? This is the first time I've ever heard that.
Never in my entire life have I heard that. No, I never heard anything about that.
That might have been a joke then.
I have any idea.
Okay. No. So with this doctor's asking, what is the best anesthetic to use if you're using doing a PDL injection on a hot tooth? PDL injection.
Okay. Well, number one, hot tooth or symptomatic irreversible pulpitis, that's the term for it. Mandibular molars that are infected are the hardest teeth in the mouth to get numb. And I give lots of lectures to endodontic societies because they want a magic answer. And you know what the answer is? There is none. I go through a whole list, okay? And I swear to you, the very last thing on my list of things to do is prayer. Because on infected mandibular molars, nothing always works. But let me give you this. Let's go off on a little bit of a tangent here. When I finish my program it's called, Is the Mandibular Block Passé? Do you still have to give the mandibular block? I talk about the Gaugates, Akinosi Vazirani, the PDL, intraosseous. I talk about with any injection you're going to be doing. Number one, I recommend buffering, in the mandible especially. I recommend buffering every injection with no matter what drug you're using. Okay, now Articaine for the people who are listening, because most dentists don't know what Articaine is, they know what Septocaine is. Most dentists will think in terms of brand names. If you infiltrate Articaine in the adult mandible by tooth number 30 or 31, you're going to get pulpal anesthesia with it. Now, no other local will do that because the bone is so thick. But Articaine works better. So what I talk about is that Articaine by mandibular block, okay, following it with a buccal infiltration of a third of a cartridge of Articaine at the apex of the tooth you're treating. Okay, but in parentheses, it says buffered. Okay, buffering Articaine, buffering any local is good, but buffering Articaine makes it as good as the drug is, and it's better than most other local anesthetics. It has a higher success rate. I'm sure you're going to get a question in a moment about paresthesia, but we'll get into that. Okay. But the point is, I don't care what drug you're using for your inferior alveolar nerve block. In the mandible, always buffer your local, buffer your articaine, and infiltrate it at the apex of the tooth you're treating. Mandibular first, second, or third molars. Okay. When you get to the premolars anterior, you don't have to do a mandibular block. You can do the incisive / mental nerve block.
Okay.
You infiltrate local outside the mental foramen, buffered, okay, buffered articaine preferably, and then you take this finger and you push the drug into that hole. And you have the 2 premolars, the canine, and the 2 incisors, virtually guaranteed 100% of the time. Nothing works all the time, but virtually 100% of the time.
So I'm going to give you that follow-up question that you already kind of brought up, and that's the paresthesia.
Sure.
So someone just asked about that. So what about the Articaine with the blocks?
There ain't no science to it. In fact, let me give you my email address, because no, seriously, because I have a whole packet of stuff I will send whomever emails me.
I will email you, Doc, and I'm going to put all that like in a file that everyone, that way they don't have to bombard you with the emails.
There's no science. It's all anecdotal evidence. Okay, we talk about scientific research. The highest level of research, the most accurate, is what's called a meta-analysis, where you take lots and lots of small studies, put all the numbers together and get this large number. That's the top of the heap. The bottom of the heap is a case report. Okay, every article that talks about Articaine and paresthesia is a case report. There is no science to it. In fact, there is more and more science, as I'll send you, basically showing that Articaine is no more neurotoxic, damages nerves, than any of the local anesthetic. Okay, in fact, you want to talk about sheer numbers in the United States every year. In the dental profession in the USA, we administer 300 million local anesthetic cartridges a year. Lidocaine is number 1 with about 44% of the market. Articaine is number 2 at 38%. Then the third one down, about 10%, is mepivacaine, carbocaine. Carbocaine, 3% primarily. The number 1 drug in producing sheer numbers of cases of paresthesia is lidocaine. But it's also the number 1 drug that's used. Okay, the one drug that I believe does have a higher risk of paresthesia is prilocaine, which is Cetanest. That's the one drug that all the case reports, if you will, have shown that prilocaine, Cetanest, does have a higher risk of paresthesia in the man.
Why is that?
Seriously, Articaine came on the market in the US in June of 2000. I started teaching in 1973, and I was involved because of my textbooks. I got involved in legal cases.
Someone score.
No, my electricity just came on.
Great. And guys, for those who are just jumping on right now, we were talking about this earlier. Dr. Malamed's in California, and they're having some issues with some wind and some fire and stuff. And so power, they do these rolling blackouts and whatnot. And Dr. Malamed just got his power back, which is going to be perfect because we're going to catch the World Series after this. And Dr. Malamed, I know you want to catch the games. I'm going to keep you on, just letting you answer a few more questions here. But you were saying?
Okay, so if you go back before Articaine in June of 2000, okay, I was involved in cases of paresthesia, as I only do defense work. And it was prilocaine, Cetanest was the usual drug. On occasion, it was lidocaine. Mepivacaine produces it. All local anesthetics can produce paresthesia. All of them can, because they're neurotoxins. They prevent drugs from carrying an impulse. So, but there's no evidence whatsoever. I'll send it to you with the email. You can send it out to your people.
Absolutely.
There's no evidence whatsoever at all.
Now, this doc just did a follow-up question. What about using Articaine in kids?
Oh, yeah. Okay, now I understand why he or she wrote the question, because it says in the package insert that it's approved for 4 years of age and above. But you know what the reason is? In the clinical studies that we did, okay, my name is the first author on the 3 phase 3 clinical trials. We enrolled patients in the studies from age 4 on up. So we proved to the FDA that Articaine is safe and effective in patients who are 4 years of age and above. That's why it says 4 years of age and above. Now, the question is it legal for a licensed doctor to use Articaine in a 3 or 2-year-old? The answer is absolutely yes. In fact, there's a growing body of literature in pediatrics that shows that Articaine is perfectly safe. In fact, I would argue that Articaine in a young child is safer than lidocaine, mepivacaine, or prilocaine.
Really?
Well, and the reason is that Articaine, we talk about amide local anesthetics and ester local anesthetics. All the new drugs are the amides, and lidocaine, mepivacaine, prilocaine, and they're metabolized in the liver. The ester type anesthetics, the old Novocaine type drugs, are metabolized in the blood. So they're gotten rid of a lot faster by the body than the amides. I'll give you an example. What's called the elimination half-life of Procaine, Novocaine, is 6 minutes. Lidocaine is 90. Okay, it takes 6 times the half-life of a drug to be eliminated from the bloodstream. So 6 times 6 is 36 minutes for Procaine. 6 times 90 is 540 minutes, or 9 hours for lidocaine. In children, the problem is overdose. Overdose occurs when blood levels of a drug get too high. Okay, Articaine has it's not an ester or an amide. It's both. It's a combination product. It's an ester and an amide. Its half-life is 27 minutes. So it's gone from the patient's bloodstream in 2 hours and 42 minutes. It's gone. So the risk of an overdose from giving too much Articaine is much lower than it is for any other amide local anesthetic. Now,
Wow.
keep in mind that 1 cartridge of any local anesthetic given intravenously rapidly will produce an overdose just like that. But I'm talking about aspirating, injecting slowly, doing it right. Articaine is less likely to produce an overdose than the other anesthetics we're using today.
Well, that's one thing I didn't know. I learned something new, and I don't think that was in this book, though.
No,
Malamed.
no, you're too old. That's
So
gotta
Dr.
buy-
Malamed, I'm going to go back to the question about the symptomatic tooth, the
Oh.
infected tooth,
Oh, okay.
and this doctor's asking, well, okay, the infected tooth, that's going to be an acidic kind of area. Wouldn't buffering actually help get anesthesia there in those instances?
The answer is yes. And again, I would recommend going back to the March 2019 ADA journal.
Okay.
The cover article dealt with that. They compared buffered lidocaine with regular lidocaine on symptomatically involved mandibular molars. And they showed in that article that Articaine buffered was much more effective than anything else.
Wow. Oh, I love that.
March 2019 ADA journal.
I'll have to look at that. So, Dr. Malamed, again, I'm going to email you and get that file there. And I did promise you that I was going to not let you miss too much of the World Series. So I'm actually going to let you, first of all, it's an honor to have you on. Like I said, I still have your book that I got in dental school. I still have it. I still refer to it.
Let me make believe I'm autographing it for you. Right
oh gosh, you know what? Next time I'm in California, I might have to swing by the dental school and bring this book with me. And it's amazing how so many people they posted pictures of their books, right? It's like a rainbow right there of all the different colors there. But Dr. Malamed, before we jump off here, I'd like to give you like the last words, and we have a good amount of people that are watching right now. Anything you'd like to say before you hop off and watch the Astros win this game?
Oh, no, the Nationals are going to do it. Okay, so listen. Yeah, number one, this whole thing was about buffering, okay? And I truly believe that buffering has many positives for dentistry. It was a study done, a survey published by Jennifer D. St. George. She is a practice management consultant. This goes back now to 2007. But how does a patient evaluate their dentist? And the number 2 and number 1 most important things were a painless injection and a dentist who doesn't hurt. Buffering helps in both of those situations. Okay, number 1, it makes it more comfortable, dramatically speeds the onset of anesthesia, less post-operative soreness, and it makes it more effective. I mean, there it is. Now, let me just mention some other things that I think are worth following up on. You mentioned the STA wand. We call it CCLAD, computer controlled local anesthetic delivery. And you know what? It goes a long way in making any injection that you think might be uncomfortable, for example, palatal or PDL. It makes them comfortable. And again, you can combine that with your buffered local anesthetic. Okay, so that we have that. We have a drug called phentolamine, which is the local anesthetic reversal agent to help make the patient get unnumb a lot faster at the end of the procedure. The brand name of that is Oraverse. There's a recently introduced the nasal spray called Covanase that you can anesthetize the maxillary. If you do it bilaterally, spray it in both nostrils from the premolar to the opposite premolar, 10 teeth without giving an injection. And think about how many patients are needle phobic.
Oh yeah.
And a benefit of that also is that you get palatal anesthesia. So that you could do subgingival preps, you could do root planing and curettage on the palate without having to give that dreaded, we think, dreaded palatal injections. I mean, these are the things that have been, they work. They actually do work. By the way, in the colors that you talked about, if anybody has my yellow book, they're old.
Guys, for those who are watching, if you have the yellow book, please comment in the comment section and put a picture of your book there, because I'm going to take a screenshot. I'm going to send it to Dr. Malamed. And
if anybody has the new edition, which is a black and red cover, I'd like to see that, because that just came out in June of this year.
Wow. Okay. You guys heard it. Do that. And like I said, I'm going to send it to Dr. Malamed. Dr. Malamed, I want to, a good friend of mine just posted a question. I want to make sure that you get to it. And he's asking using, hold on, let me look here. The Ligaject. Yeah. Syringe to do, to do these PDLs with Articaine.
Okay.
How do you feel about that? He wants to know your opinion on that. Instead of blocks.
Oh, look, I talked about alternatives to giving the mandibular block, and the PDL injection is fantastic. And Articaine, okay, is a great drug. I have a problem with the devices like the Ligaject. Okay. And the reason is you're putting 0.2 of 1 ml of anesthetic into a non-existent space, the PDL. And I give it, watch my hand, I'm holding a regular syringe in my hand and I'm doing that. There's a lot of resistance to the drug going in. And when you do it like that, it doesn't hurt the patient. The drug is going to go from the PDL into the interproximal bone down to the apex of the tooth. When you have the Ligaject, or the other one is called the Peri-Press, okay? You hold it in your hand and you squeeze a trigger. And it puts the same amount of local anesthetic in, boom, just like that. But you're putting in 0.2 of 1 ml is the thickness of that rubber stopper on the cartridge. You're putting it in rapidly into it, you're tearing the PDL. So it hurts instantaneously, but it goes away because you're putting a local anesthetic in. But later, when the anesthetic wears off, okay, that tissue is now inflamed and it's going to hurt like hell. So and by the way, those devices, Peri-Press, Ligaject, it's virtually impossible to inject slowly with them. They're designed to just squeeze the trigger and push it in. So I would prefer to use a 27 gauge short needle, sit there and just push as hard as I can. And what it does, if you can see my thumb anymore, it's getting dark in here, I'm sorry, but it hurts me right there as I'm pushing down on the plunger, but it doesn't hurt the patient at all. And it works. PDLs are great. You can use it.
I appreciate you answering that question. And Marty, you just got the answer right there. He loves doing that, using that, that syringe. So thank you so much for answering that. And Dr. Malamed, there's so many people that are just, I want to screenshot it. I want to send it to you. There's so many people that are so happy that you're.
Light on.
Sure, yeah.
Look, there's Dr. Malamed, finally.
So Dr. Malamed, there's so many people that are saying like, what an honor to have you on. They're enjoying everything that you're saying here. Could we get you to come back again? Because guys, if you want Dr. Malamed to come back, you got to type in the comment section, Malamed. Okay, you got to type in the comment section. We get enough of that, I'm going to send it to him. And he said it. But Dr. Malamed, we'd love to have you back on. It was so informative. And would you consider coming back on?
Absolutely. Yeah, this is fun. I mean, we went off on a lot of tangents here, but I love it.
Well, you know what? I mean, there's when you're in dental school, everyone knows what a netter is, right? Everyone knows Stedman and everyone knows Malamed.
Yeah. Where'd you go to school?
I went to Baylor, but they changed the school. It's Texas A&M now, unfortunately. But I went to Baylor, and like I said, this book, many a test, this one in the medical emergency book that you wrote, many a test came from that, and I still use this book every day. So, Dr. Malamed, thank you so much for jumping on.
Oh, my pleasure. I'd love to come back and do it again.
Absolutely. Thank you so much, Dr. Malamed. And depending on how that game goes, I might email you and talk about something about the baseball game, depending on how it goes.
Depending on how it goes, I'll email you too.
All right, dog. Take care.
Bye-bye.
All right, guys. So stick around here. We're actually going to bring on somebody. And now Dr. Malamed was talking about buffering anesthetic. And I told you guys that we were going to have a company that deals with buffering anesthetic. So we're actually going to bring that rep on right now. And like I said, I am a big fan of doing that. And what Dr. Malamed said, what are the positives? What are the reasons why you want to buffer anesthetic, right? Number one, patient gets numb faster. Number two, it's more comfortable. Number three, afterwards, they're not in discomfort. That's coming from the man himself. Now, I've done it both ways. I used this company's system, and I also did the home brew myself, or the do-it-yourself. And so what he said about doing it yourself, yeah, it is thrifty. It can be somewhat nifty, but the problem with that is he just said it himself, is sometimes that range could be really big, right? And if it's, if you go too far on one end, you cause that swelling. And it's happened to me before. So hold on, we're going to try to bring that rep on right now. Hopefully he sees it there. He's going to click and he's going to jump on soon. So you guys stay on here. Don't jump off here. I know Dr. Malamed jumps off. And guys, also, if you can, type in the comments section, Malamed, if you want Dr. Malamed to come back on. I'll take a screen. He obviously does not get on Facebook very much, but we correspond a lot via email. And so I'll take a screenshot, I'll show him, and we'll bring him back on, and you guys can ask more questions. But that was super informative. I'm waiting on this rep to jump on, and we'll talk about their system and also a nifty thrifty deal. So hang tight here. Okay, so Craig, thanks for jumping on here. Guys, Craig is from Onpharma, and Dr. Malamed was just talking about that. So first of all, let me give you guys a little background here. Craig is actually on vacation. He's in Costa Rica right now. And so that's why there's like this little lag and whatnot, but he's in Costa Rica. He wanted to jump on because he's the main man with Onpharma. We were just talking about that. Dr. Malamed and I, we were talking about buffering anesthetic. And your system was one of the systems that he really liked a lot, because the thing is that each time you use it, you know exactly what the pH is going to be. Now, when you do your do-it-yourself style, that's what he calls it, sometimes it works really good. And sometimes your patient leaves all swollen, and that's not good at all. That's not good at all.
Right.
So Craig, let's talk about this. The system, how does it work exactly? Okay, because Dr. Malamed talked about the science behind it. Everyone got really excited.
Sure.
We know why it's important, right?
Okay.
Get faster anesthesia.
Absolutely.
Feels more comfortable.
Yep. So the system, Dr. Mick Falco invented the system back in 2008 is when we started the project. We came to market in 2012, and everything that Dr. Malamed is talking about is exactly the reason why you want to be able to buffer. With the Onset buffering system, the biggest advantage, and Dr. Malamed talked about this, is that you're going to know what your pH is every single injection, because we manufacture our own at an exact pH around 7.4. And so what that's going to do is make your buffering very predictable for you. So every time you give an injection, you're going to know exactly where you're at. And I know you and I talked about that before. It's extremely helpful to know exactly what the pH level is going to be.
That is so important. And another big thing, and we did a video, guys, if Craig looks familiar, guys, we did a video while we're at the Southwest Dental Conference here. It's the same guy here. I dragged him on his vacation. Yeah, I dragged him while he's on vacation to jump on here. But Dr. Malamed brought up something that was really important that the Onset system didn't do before, way back in the day. And that was buffering Articaine. And he was saying how that is just, that combination is one of the best combinations when you're giving local anesthetic. Talk about how the new system now allows you to do that.
Yeah, absolutely. So we've been in the marketplace since 2012. And there's been some great changes, some huge changes in the science. The number one, when we went to market, we were able to buffer or just recommend buffering lidocaine. And of course, a lot of doctors love buffering or using other anesthetics. So now you can actually buffer any anesthetic you want, which is a huge improvement for our system. As Dr. Malamed said, our system is the only one that allows you to be able to do that at a consistent. The other thing, when we first launched, our sodium bicarbonate that we manufactured had a shelf life of 1 day, about 24 hours, because sodium bicarbonate is very volatile and wants to come out of solution. And so we did some more research, and now, Dr. Vo, even since I spoke with you about 2 weeks ago, we have new research. We can actually use that one cartridge of sodium bicarbonate up to 7 days.
That's amazing, because when I first started,
and then the third thing that we changed.
I remember when I first started using Onset, I had to use it within that day.
Within 1 day, exactly, for best results. And now you can use it over a whole 7 days, which is fantastic, because some doctors maybe work, Monday, Tuesday, Thursday, whatever it is, you can now use a whole week. And that was a big concern, because a lot of doctors thought they're going to be wasting a lot of the sodium bicarbonate, but now you're not going to. The other great benefit with Onset is that we manufacture it in our own 3 milliliter cartridge. And we're going to give you enough sodium bicarbonate to do 20 injections. And the reason why that's important, we did some surveys and we found out that the average dentist sees between 4 and 7 patients a day that need that first injection of local anesthetic, right? So if the average dentist only works 4 days a week, that's right around 20 injections a week. We know that doctors don't like to waste things, right? So that's going to be enough just using 1 cartridge of sodium bicarbonate and one of what we call our cartridge connector, which allows you to mix the 2 solutions in a sterile environment. So the whole system now, Dr. Vo, from when you started using it, when you were an early adopter, has dramatically improved and changed. And we're so excited for all of your listeners to be able to take advantage of it and really dive in and see if it makes sense for the practice.
Yeah, and I did a poll recently, and on that poll, people were talking about different ways where they made local anesthetic comfortable. And I told Dr. Malamed that only a handful of people talked about buffering, and he talked about it. But you know what? I think that now people hear about this. I think a lot more people are going to want to start doing buffering, and they want to do it the right way. So Craig, let me ask you this, because a lot of times, so they understand why it is, beneficial for the patient, for the practitioner. We also know that the different advancement in the Onset system makes it a lot more cost effective. Now, the biggest thing is, Dr. Malamed touched on this, with other systems, they make you deliver the anesthetic in a different way. Onset does it. So let's put that myth to rest, that Onset is going to make you have to give local anesthetic in a different way. So kind of just briefly talk about
I appreciate the opportunity, because what Dr. Falco, he's a practicing dentist in Monterey, California. He knows that he works very hard on his own techniques. The last thing we wanted to do was change the way the doctor injection. So the way it's going to work is that we have what's called the Onset mixing pen, and that's a delivery device. All you're going to do is mix the 2 solutions in a sterile environment. Then you're going to take your cartridge of local anesthetic of choice. You're going to put it into your syringe. You're going to give your same normal technique that you've always done. We're just going to activate the anesthetic to give you times more of the base form of the active form of the anesthetic that you need to get your patient numb. And that's about as much science as you're really going to need. I mean, Dr. Malamed really touched on the high levels of it, but to be brutally honest, do you want to hurt your patients or not? It's not, does buffering work? We know that it works. We've had tens of thousands of doctors that use
Dr. Malamed just said
are you willing to, he just said are you willing to try it? I don't want to sound like a commercial, but the reason why I wanted to come on is we just, at Onpharma, we really truly just want people to try it. We just want you to see if it makes difference in your practice. Is it make a difference for your patient? And does it make a difference for you? That's the big game changer.
Well, guys, for those who are watching right now, if you're not getting excited about this, I don't know what will get you excited. But if you guys want a nifty, thrifty deal, type it in the comment section, Onset, type in the comment section there, and we'll talk about the nifty, thrifty deal. But so Craig, let me ask you this. Okay, so normally the like 1 cartridge of the sodium bicarbonate to mix. How you said how many injections could you get out of that?
So for that 1 cartridge, when we send it to you, it's going to be in our pressurized tray. And that pressurized tray that holds it at the perfect pH is good for 3 years from the manufacturing date. Once you release it and put it in the Onset mixing pen, it's now good for 7 days. Okay.
7 days.
And that 1 cartridge, Dr. Vo, is now going to allow you to buffer up to 20 cartridges of local anesthetic. When we first started, we were dialing the pen up to 18.18 milliliters. We now have new research. You can dial the pen all the way down to 0.09 milliliters for all of your injections. So when you were using it, and this was an epiphany for you, you kind of said, wait a minute, when I was first using it, are you saying I'm now paying 50% less than I did just a couple years ago? And the answer is yes. It's now half the price. If any of you tried Onset before, we would love you to try it again. You can now buffer any anesthetic you want. You can use one cartridge and one cartridge connector over a whole 7 days. We'd love to have you try it again.
Well, Craig, I'm going to put you on the spot right now.
All right.
I'm going to put you on the spot. I know you've been just surfing and having a great time in Costa Rica. Just
I just saw a volcano today. It was very cool.
I want to put you on the spot because you know what? I just looked over in the Facebook group and I have so many people type it in the comments section. Onset. And guys, if you want a Nifty Thrifty deal, keep typing that Onset. I see so many people typing that. They want a deal. They heard Dr. Malamed. They heard what you had to say. Now they're like, okay, what's the deal? So Craig, what can you do for our group? You've been a member of this group. You see how passionate people get about that. Yep. And they're really passionate about Onset here. What can you do for the members here at Nifty Thrifty? All
right. I've been really thinking about this, Dr. Vo, and I want to make sure that I do something that really motivates your folks to try it. That's all. We just know that if you try it, you're going to love it. So here's what I'm going to do for you. The Onset introductory kit is usually $499. And what you get with that is enough sodium bicarbonate and cartridge connectors to last you a whole month or 80 injections. You also get the Onset mixing pen, which has a $215 value, okay? I talked to my CEO, my CFO. What we'd love to do for your group is that we'd like to offer you guys 10% off or $50 off the starter, the initial order, which is $449. But on top of that, I'm also going to guarantee it. I'm going to give every one of your listeners a 120-day pen guarantee. And what that means, Dr. Vo, if they're willing to buy the starter kit, the introductory order, and they're willing to take a 15-minute Zoom call just like this with one of my Onset specialists, and then they give me a 5-minute phone call to follow that they got the results. If they're not 100% love the product, I'll give them back the cost of the Onset mixing pen, no questions asked.
Wait,
so
hold up.
I want to take every roadblock out.
Wait a minute. Okay, I got to make sure you said what you said. So guys, okay. Type in Onset if you like what you just heard there, because we got them on video here. I got to make sure I just heard that. So you're saying deal part one, you're going to give 10% off the package, the introductory package.
10% off.
And then you said something that really caught my attention. You are so confident that they're going to love this system, just like Dr. Malamed loves the system, just like I love the system. You're going to give them an opportunity, if they're not satisfied, to get a refund from the mixing pen, the cost of the mixing pen.
That's correct. Yep. I'm going to give them
all they have to do is what?
Right.
What do they? You said all they have to do.
All they have to do is call tomorrow. Is call the Onset specialist team tomorrow. It's 877-336-6738. Hit prompt number 2 for sales and training. And my Onset specialist team is ready to be able to take your order. Tell them you want a Nifty Thrifty deal. That's all you got to say. Yeah. And they're going to give you all that. And they're going to give you free shipping. Kaboom. That's it.
What else do you guys want?
I'm that confident, Dr. Vo.
I mean, Craig just took away, guys, all the risks there, right? If you don't like it, okay, and all you got to do is you got to really give it a fair shake. And if you don't like it, you can return it. But he's that confident that you're going to love it, just like Dr. Malamed loves it, just how I love it.
I've been in doctors' offices, Dr. Vo, and I've seen patients in the chair that come in so scared, and I've sat there and we buffered the cartridge with the doc. Amazing what it does for the patients. I used to be one of those kids that would grab onto the chair for dear life. And I just want your doctors to try it. It's that simple. And you can also our website at onpharma.com. That's onpharma.com. There's great videos there. There's a training video if you want to see how the Onset system works. You can also go to all of our science. If you're one of those guys who want to dig into the science to figure it out, Every single article ever written on buffering is in our science guide too. So we are very, very confident. It's just time for your listeners to take a dive in, try it. Just try it. That's all I'm asking you to do.
I love it. Craig, thank you so much for jumping on. I promised
Absolutely.
you that I was going to keep you on here out of your vacation. Hopefully your wife will forgive me for that, but I wanted to bring you
no
on
problem.
specifically because people remembered you from our last video and you are so knowledgeable about this and we wanted to bring you on. So guys, later on, I'm going to put all that in the comments section. Okay. Ask for the Nifty Thrifty deal. And literally, there's really not that much risk. They're going to put their money where their mouth is. They're so confident that you're going to like
totally
it.
Putting our money where our mouth is, Dr. Vo. We totally believe that your listeners are going to love it. So please take me up on my offer.
I love it.
Prove
Craig,
me
thank
wrong.
you so much. Craig, thank you so much for jumping on. I'll let you get back to your vacation there. Have a great time.
All right.
And when you come back, we'll talk about a little bit more about Onset when you come back stateside.
Great, Dr. Vo. Thank you for having us on today. Hope everybody has a great night. And I'm going to say go Houston because they're in the area.
I love it. I love it. Thanks, Craig.
All right,
have a great vacation.
Have a great
Guys,
night.
thanks for watching. We'll see y'all next time.
All right. Take care.